Welcome to updates in Factor VIIIa Mimetics, advancing hemophilia treatment today and tomorrow.
Hello, I'm Cihan. I am a hematologist from the Medical University of Vienna in Austria.
Hello, my name is Carmen Escuriola and I'm the director of the Hemophilia Center Rhine-Main, Frankfurt, Germany.
My name is Cedric Hermans. I'm currently heading the Division of Hematology as well as the Hemophilia Treatment Center at the Saint-Luc University Hospital based in Brussels, Belgium.
This education will help you improve your abilities to case scenario Robbie, age 19. Robbie is an incoming college student with severe hemophilia A. How would you describe the differences between first and second generation factor mimetics to Robbie? How would you describe the differences between first and second generation factor mimetics to a patient?
So talking to patients, I think we have to tell them that Mim8 is not a bioequivalent to emicizumab. There are smooth changes which intend to achieve a better hemostatic efficacy. But with these changes, they were able to provide a constant or a therapeutic agent with a lower volume. And particularly for this 19-year-old patient, this might mean that he should be able to use this drug once monthly with one single injection. I think this is very important, particularly for patients. We are talking about how beneficial the subcutaneous treatment is, but we also have patients with a needle phobia. For them, it's even the subcutaneous administration is a problem. So having the opportunity to inject this once monthly, I think it's really a beneficial situation for this, a benefit for this patient.
Absolutely. And I think also there is a special device here for administration of this new generation of factor VIII mimetic with a specific pen and self-injectable pen here. So this might be also a difference.
Yeah, and my understanding is that, it's possible to improve bispecific antibodies. So, this is a new era in the treatment for patients, but clearly, it's possible to improve them. And the difficulty is how can we demonstrate that one bispecific is different? The only approach today is a thrombin generation. It has limitation, but the data in vitro show that Mim8 has the potential to generate more thrombin. And that has multiple implications. That means that you can reduce the volume that you inject to the patient, so you can make the treatment probably more convenient with a better tolerance, and maybe, on the treatment schedule, because from the results of the trial, we could see that many patients could be treated once a month without any loss of effect, after 3-4 weeks. So, yeah, well, that could be, at the moment, the implication are mainly focus on how we use the drug, how it is administered. I think it's premature to say the patient that he will be better protected. The future will tell us this, maybe. But for the moment, yes, I think that from the practical logistic point of view, the treatment could be to some extent facilitated. That I'm sure that your patient would be happy to have a smaller volume once a month. So that can make the difference. And Novo Nordisk has introduced, they had a long experience with injection pens. So
Yes, and I think long-term real-world data will show us coming back to this 19-year-old potentially is a very physically active patient, and we will see whether whether these in vitro data can be confirmed in real world.
Absolutely, I agree. I mean, we can probably not answer this question entirely, how the new mechanism like of action, the changes, how the first like evidence from in vitro study where we expect more potencies translating to clinical outcomes. I would love to see more data once my mate is licensed here. Yeah.
At the same time, having this, this diversity, I think that should be very important, because it's likely that emicizumab is not the ideal treatment option for all the patients. So having the choice and having other agents coming in the future, I think that would help us.
Yes, of course, and having in our mind that particularly in children less than 12 years, the injection of emicizumab has been described to be quite painful, discomfortable for the patients. If we look at the data with Mim8, it really looks like that there are less injection sites.
Although Mim8 has not yet validated
In very small children.
in very small children. So this is a limitation. So, data need to be collected in the future for your children. This is me.
I would like to add another aspect to it. I assume that we will have with those drugs a good bleed control, but what is the long-term effect on joints, joint health here? So, and this will be also relevant for patients, especially if a patient is young, has pristine joints, and he wants to switch a therapy. So we need to provide maybe more data on what it adds to preserving a really good joint health status.
Yes, I think this is a very important point, because I think we can really assume that this patient will be very active, will have many sportive activities. Potentially, he will have a profession where he will be really physically active. So I think in order to check the joints, we should not only focus on breakthrough bleeds. We have to monitor the joint status very cautiously, including ultrasound, including a very deep, intensive physical examination, potentially other evaluations such as gait analysis and so on as well.
Yeah, and I would say that, well, clearly this higher potential to generate thrombin, the future will tell us whether this translates into a clinical impact. I mean, better protection for the future, or less need for adjuvant therapy. Maybe, you could perform more procedure without an adjunctive use of factor VIII. So the future will tell us. But when you look at the in vitro data and the ability of that specific bispecific antibody to generate thrombin, why not? But the future will tell us.
Yes, you're absolutely right. And the future would challenge us as well, because there will be surely patients who are on factor VIII treatment who would like to switch to such a agent, but potentially there will be patients on emicizumab who would like to switch. So how are we going to manage the switch from one bispecific antibody to the other one, having in our minds this long half-life?
I think there was a very specific study that will tell us how this is. Like, there is the FVIIIa study with emicizumab, where patients on emicizumab were switched to Mim8, just without like washout, just without continuing the next injection with Mim8. And once we have the full results of this study, maybe we can say something how well this has worked, whether there are safety signals or not. But I bet.
Well, it would be nice to see, to what extent, we always consider that the patient on emicizumab has an equivalent factor VIII level around 10-15%. So would Mim8 have the potential to provide, higher equivalent factor VIII activity? I think this is what we hope the future will tell us. But it's when you look at the mode of action and the affinity for the clotting factor and how this antibody has been designed, I think the potential is there.
What might NXT007 and INO8 hold for the future?
Well, clearly, since we are now raising the ambitions up with these bispecific antibodies, it's nice to see that the next one could be NXT007, which is a super or hyper emicizumab. So again, the future will tell us, but the preliminary data are also quite promising. It's very likely that this drug also has the potential to generate more thrombin, and so it's a little bit premature because we are early, but clinical trials are ongoing and will tell us.
Yes, we're absolutely right. And this is particularly true for the 8, where we are at the very, very early stage. But I think from the patient's point of view, there will be a decision whether they go for the needle or whether they go for the pill, which will be a daily intake of the pill, of the drug. So let's see whatever they...
What's really impressive is the technology that is used there. They develop something that was, who could think that, we would ever discuss a factor VIII given by mouth. But valuing, as you beautifully showed, this nanobody snack and binding to endogenous albumin, this is great.
Yes.
This is great. So, yeah, but what I really looking forward to have this discussion with the patient about oral factor VIII. You will never forget that they had CF. What do you think?
This is so exciting. So I just see you smiling and your eyes shining, talking about this. I think it will be groundbreaking. I think this will be probably the next game changer if we have an oral drug. Yeah, so this will be another game changer here. But I'm still a little bit conservative. I want to wait for the studies to come, and then also this is also important. I think I would also would like to discuss how should we really design future studies with these new drugs to really understand their potential. So is it we were talking about like routes of administrations and devices that could be used, but at the end, so I would hope that we will have in hemophilia like studies where we can really compare drugs, which would be difficult. So in addition to, of course, this new technology that are used, yeah.
Factor mimetics are part of a broader range of investigational therapies for hemophilia A, aimed at improving bleed control, treatment adherence, and quality of life. Factor VIII is an essential cofactor that accelerates factor X activation by factor IXa during normal blood clotting. However, patients with hemophilia A are deficient in factor VIII, resulting in poor hemostasis. Factor VIIIa recognizes multiple binding sites on factor IXa and factor X and has full cofactor activity, including promoting phospholipid binding, stabilizing factor IXa active site, bridging factor IXa to factor X. Factor mimetics are engineered molecules that mimic the function of clotting factor VIII, without being identical copies. Instead of replacing factor VIII, they bridge the gap in the clotting process using different mechanisms. Factor mimetics offer several advantages over factor replacement. They are delivered via subcutaneous administration instead of IV infusions. They have longer durability and less frequent dosing, ranging from weekly to bi-monthly. And they are effective in patients with inhibitors. Emicizumab is a bispecific monoclonal antibody approved in 2017 for prophylactic treatment of hemophilia A for patients with or without inhibitors. It binds activated factor IX and factor X, mimicking the cofactor function of factor VIIIa in the coagulation cascade. Next-generation bispecific antibodies under investigation include NXT007, which has structural modifications designed to enhance binding and reduce dosing frequency, MIME-8, which better stimulates proteolytic activity of factor IXa to activate factor X. Preclinical and early clinical data suggest it may allow effective clotting activity at lower doses, with extended dosing intervals under investigation. In FVIIIa, an oral factor mimetic that is approximately 5 times smaller than immunoglobulin G antibodies, conjugated to fatty acids to bind serum albumin, prolonging the plasma half-life of the agent. Comparative studies indicate that next-generation mimetics are significantly more potent than first-generation agents, both in vitro and in animal models. Key areas of ongoing research include safety and immunogenicity, long-term efficacy and durability, comparative effectiveness versus standard factor replacement. Thrombin generation serves as a key indicator of factor VIII mimetic potency, reflecting their ability to enhance factor IXa-mediated factor X activation and overall hemostatic efficacy. Current safety considerations for factor mimetics include thrombosis risk, particularly in combination with activated prothrombin complex concentrate. Experts now recommend using activated recombinant factor VIIa as the preferred bypassing agent for breakthrough bleeding or surgery during therapy. Factor mimetic therapy represents one of several evolving strategies in comprehensive hemophilia care that supports individualized treatment goals. Treatment decisions in hemophilia should be individualized based on clinical needs, access, and patient preferences.
The properties, and particularly for the clinical implication of this treatment, shows you that factor VIIIa mimetics typically are administered subcutaneously. They have long half-lives, providing an infrequent, rare or seldom administration, and very importantly, they are not affected by factor VIII antibodies, and they themselves have very limited immunogenicity.
Colleagues like Cedric, among us today, they also advocate that these new therapies, that these new therapies should be put on the list of essential medicines of the World Federation of World Health Organization. So this is a long list, and I agree, because more and more people are using these therapies here, and they deserve to be put on this therapy because they are effective and they are safe here.
We have both approved and investigational factor products here in this field. So emicizumab, which has been approved in 2017 for adults and pediatric patients of all ages, and which is indicated for routine prophylaxis to prevent or to reduce the frequency of bleeding episodes in people with hemophilia A, with and without inhibitors. And this is once more a typical characteristic. All those factor VIII mimetics are designed for prophylactic treatment. And then we have the MIME-8, the NXT007, and in FVIIIa, 3 products which are still under clinical development. The most striking differences is that natural factor VIII has a full cofactor activity. It promotes phospholipid binding, stabilizes factor IXa active site, and bridges factor IXa to 10. And this is particularly the partial cofactor activity what emicizumab has. Its task is to bridge factor IXa to factor 10 and to generate thrombin. This is achieved with a dosing strategy, including a loading dose of 3 milligram per kilogram body weights given at weekly intervals for 4 weeks, and then followed by a maintenance dose, which can be given weekly, bi-weekly, or monthly. Now coming to the next generation factor VIIIa mimetics, and they are no bioequivalents, they are different. So MIME-8, which is an IgG4 as well, has a monovalent anti-factor IXa arm that targets the factor VIIIa binding helix enhancing the factor 9A proteolytic activity and the factor 10 activation. And the rate of factor 10 activation is 31-fold compared to emicizumab. The dosing strategy is adapted according to weight groups. It's not adapted according to the precise weight in kilogram. And it is administered subcutaneously using an injection pen. And what we can see until now, and let's focus on outcome of bleeds, that about 2/3 of the patients being treated either weekly or monthly were bleed free, leading to a median ABR of 0. So that's why we are now more focused on mean ABR, what you can see in this figure, and mean ABR was once more reduced with the either once weekly or once monthly application of MIME-8 compared to the previous clotting factor prophylaxis group. And on the right side of this slide, you can really see that compared to the previous clotting factor therapy, there are advantages for the different subgroups of bleeds with the use of MIME-8. Looking for safety, and I want to shorten this, I think the most important or the AE of special interest is the occurrence of thromboembolic events. And in both arms, the weekly as well as the monthly treatment arm, no thromboembolic events could be observed. There were 2 patients who discontinued with the product. However, this was one patient with coronary artery disease, which was unlikely to be associated with this drug, and one patient with a sleeping disorder and dyspepsia. If we could look at the injection site reactions, we can say that in both arms, the once weekly as well as the once monthly treatment arms, they were very low, around 10%. So no safety concerns were observed in patients treated with MIME-8. And this could also shown in the FVIIIa 5 studies where patients were switched from emicizumab to MIME-8. The switch was well tolerated over 26 weeks in 68 patients with mostly mild, moderate TIAs, no thromboembolic events, hypersensitivity or discontinuations. Now coming to NXT007, here we also have an bispecific antibody, but structural changes have been made. Particularly you can see this in the light change of these molecules. Here mutations were introduced to each chain to enhance the cofactor activity and to generate more thrombin. The dosing strategy has to be defined. Optimal dose is still being determined, and this product is also given subcutaneously. Now, there is a study conducted in healthy volunteers, 40 in total, which were assigned to different dosing cohorts and who received a single dose of NXT007. The most important thing was that the administration at different doses was safe. 30% developed anti-drug antibodies. However, this was a dose-dependent effect and did not impact safety. And you can see on this curve that an APTT shortening was observed with increasing doses of NXT007. Also an increased thrombin generation, this is not shown here on this slide, could be observed. And newest data showed that in this trial in the trial with hemophilia patients, NXT007 led to decrease in ABR compared to baseline in hemophilia A, with no safety concerns up to the highest dose cohort. Now, coming to a total different molecule, which is INO8. I told you that factor VIIIa mimetics are typically delivered subcutaneously, but this is not a bispecific antibody anymore. This is a bidomain nanobody, which is about 5-fold smaller than the IgG antibodies and which is delivered orally. So um, typical attributes of this molecule is the so-called protection technology, where serum albumin is bound to conjugated fatty acids with the aim to prolong half-life. And this really succeeded, at least in beagle dogs, as shown here, 115 hours. Of course, there is a program planned called Voyager, a phase 1 study of INO8, where healthy men, adult men, will be randomized according to be treated with ascending doses intravenously and ascending doses orally. And the objective of this study is to investigate, of course, safety, tolerability, pharmacokinetics, and pharmacodynamics.
So, and what can we expect from the next generation of factor VIII therapies and mimetics? Of course, we had heard some first results, but we expect, of course, enhanced bleeding protection, because the next generation of factor VIII therapies, as we have learned, they are more potent. They provide a sustained factor VIII mimetic activity more than the current first generation. The first data that we have indicate a lower ABR, but we will see and wait for the total report of the trials that are ongoing, or for the future trials that are performed. And then dosing and administration is a little bit different, and you already referred to. First of all, there is, like with the new factor VIII mimetics, especially with Mim8, there will be a self-injectable pen. So I think I found it amazing. So if you have seen this pen, it's really cool. Something very cool. And with INO8, a completely new rule of administration, oral route. So, I mean, we always have dreamed of having an oral drug. That would be a huge progress here. Of course, then there is the question of dosing intervals. Can we extend them, or can we adjust them here? But still, I think with these novel drugs, they have, according to the first data that we have from the phase 3 trial of Mim8, or the first phase 1 and 2 trials of NXT007, they have an acceptable safety, but still we have to observe their long-term effects.
Robbie was counseled on the following points regarding new factor IXa mimetics. As Robbie's current regimen is effective and well tolerated, there is no immediate need to switch therapies. Robbie was encouraged to stay informed about clinical trial results and to discuss any interest in trial participation or future therapy changes with his hematologist.